Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. And today we have some more rules in the clinical care tips category. Rule number 67. You can ventilate a child forever. Ventilating a patient with bag and mask, especially a child, is a fairly easy procedure to do. The younger the child, the smaller the child, the easier. I think people tend to forget that if there's no airway obstruction anywhere, for the most part, you can really ventilate a child forever. And we often start worrying about the intubation and the intubation tray and not being able to intubate or not being comfortable by intubate. I can certainly appreciate that many providers may not be comfortable nor has the skill to intubate, which is why I think it is important to remember that for the most part, ventilating with bag and masks, especially in kids, works very well. Especially if there's help around, which there should always be help around in the hospital with a nurse or a respiratory therapist, is something that you can do for a long time while calling for help, and really there should always be help. RRT, PICU, anesthesia, someone should always be able to help you. If you walk into a room as a trainee or a resident with a child who doesn't seem to be breathing and you're not comfortable or familiar with intubation, don't worry about it. Get the bag, get the mask, and start opening the airway with the jaw thrust and start ventilating. It's easy, it's simple, and you can really help the child a lot. Bring up the oxygen saturation, reduce the CO2 if you can even see it, and take care of business. Keep in mind that when you're ventilating a child for a while, the stomach may get distended, which doesn't really help. Putting an NG tube at some point to deflate the stomach may go a long way. But for the most part, you can ventilate a child forever. Open the airway with the jaw thrust and start bag and mask. Simple, easy, and can really save a life. Don't worry about intubation as long as you can ventilate the child, ventilate him or her while you're calling for help. And again, there should always be help around. Rule number 68. Always use SOAP for sedations. SOAP meaning S-O-A-P. We'll get to it. So in my hospital, we have a lot of procedures, and many times I find myself sedating kids for painful procedures. Most of the time it's a fracture reduction by the orthopedic PA or myself. And because it's a painful procedure and I need the child to be somewhat cooperative, I almost always use ketamine. Sometimes I use ketamine with propofol, but not very often. I personally am a very big fan of ketamine. It is the only drug that I know that is sedative, amnestic, and analgesic, so it works great for painful procedures. And I certainly recognize that conscious sedation with ketamine is very safe. I rarely have any complications. However, being a good ER doctor, I try to be ready for the worst and be a step ahead, as we discussed in previous episodes. What does that mean? I always have SOAP for sedations. Suction, oxygen, airway, and pharmacy. So every time I do a sedation, especially with ketamine, which is known to cause bronchial secretions, I always have suction ready to go. Suctioning a child who's sedated can go a very long way and resolve a lot of issues. So always have suction ready to go. Oxygen. You can never go wrong placing a sedated child on oxygen. In my hospital, I even have the privilege of having a CO2 monitor and a respiratory therapist in the room with me the whole time, which really helps. But in my mind, having oxygen before sedation is a must. Now, it's important to remember that if the child stops breathing, his oxygen saturation may remain high for a while, so looking at the breathing and looking at the chest rise is very important, especially if you don't have a CO2 monitor, but it's something I always worry about. Remember, a normal pulse ox in a sedated child is not particularly reassuring. The child may retain CO2 without you knowing about it. So if you don't have a CO2 monitor, make sure you're looking for chest rise. The next letter in my acronym SOAP is A. A stands for airway. Make sure you have all the airway equipment you need. So there's always a chance, especially with propofol, that the child just goes apneic. And you gotta be ready with the bag and mask that is appropriate for the child's size. So before starting a sedation, I always make sure I have a bag and a mask, appropriate size, ready to go. I always open the bag and put it right by me just in case I need it. The last letter in the acronym SOAP is for pharmacy. That's not something I always do, but at least I keep it in the back of my mind. Sometimes you may need a medication to reverse the sedation process. So, as you guys hopefully all know, with ketamine, there's always a risk of laryngospasms. That's why I always inject ketamine slowly to avoid the laryngospasm. But if there is laryngospasm, the first thing to do is open the airway. The second thing to do, if it still doesn't help, is to ventilate the child with a bag and mask, which we discussed is super easy. And the last thing you may need to do is paralyze the child to prevent and stop those laryngospasms. So knowing in the back of your mind that you may need to order rocuronium and what the dose would be for this child is very, very helpful. So again, rule number 68, always have soap for sedations: suction, oxygen, airway, and pharmacy. Rule number 69, rules are meant to be broken. And that rule basically means that some kids sometimes present in a very unusual fashion. I'm probably shooting myself in the foot discussing this rule since my podcast is called PEM Rules and I like to talk about the rules, but some rules are just meant to be broken. It is important to keep in mind that life is not a set of rules, so things can change, present unusually, and one must always think outside the box. A good example is a story that I hear every once in a while from a colleague about a patient presenting with abdominal pain who was actually in DKA. So DKA should have polyuria, polydipsia, weight loss, dehydration, but every once in a while from a colleague, I hear about a patient that just presented with abdominal pain thinking he has a surgical abdomen when the kid actually was in DKA. First time presentation of diabetes. So it's important to keep in mind that some kids just break the rules. My favorite story of mine from this rule is one of my very first patient as an attending. I would never forget it. So this took place in 2016. In one of my very first shifts as an attending, I had a 3 or 4-year-old who presented with limping. Mom said that for the last week or two, the child has been limping. She actually took him to a different ER the day before. They did a bunch of x-rays of his extremities and everything was normal. So he was sent home with the diagnosis of a sprain or strain, which I hope by now you learned from my podcast that a sprain or a strain in kids doesn't really exist and kids always break. However, his x-ray was normal. I'm not exactly sure what the diagnosis was, but he was sent home. He continued to limp, so mom brought him to us. And when I examined the child, I saw no swelling or tenderness anywhere along his extremity, which seemed very odd because in my mind, if you're limping from a musculoskeletal reason, there really should be some tenderness. I proceeded to perform a Babinski on the child, which unfortunately was positive, and after a head CT revealed brain tumor, we got our answer. So that's a very good example of a child that, in quotes, broke the rules. Limping doesn't always mean a musculoskeletal problem. In my mind, if you're limping from a musculoskeletal problem, there should be some swelling, some point tenderness, something to support a musculoskeletal issue. However, since this child had none and had a positive Babinski, I was obviously very worried about a CNS process, scanned his head, and unfortunately found the tumor. So remember, some rules are just meant to be broken. Unfortunately, not all kids read the textbooks and present in a usual fashion. And that is it for today, guys. Thank you very much for listening and tuning in. I hope you enjoyed the episodes. Let's review what we learned. Rule number 67. You can ventilate a child forever. If you don't know how to intubate, if you don't feel comfortable intubating, call for help, open the airway, get the bag and mask, and start ventilating. For the most part, in most situations, you can ventilate a child forever. Rule number 68. Always use soap for sedations: suction, oxygen, airway, and pharmacy. Rule number 69. Remember, rules are meant to be broken. Not all kids present the way you learned in the textbook. It's totally fine. Open your mind, expand your differential, and think about the case before you anchor in. Thanks again for listening, guys. I hope you liked the episode. I hope you liked the outro. See you next time.